Occupational English Test. This test has 3 parts. In each part, you'll hear a number of different extracts. At the start of each extract, you'll hear this sound. You'll have time to read the questions before you hear each extract, and you'll hear each extract once only. Complete your answers as you listen. At the end of the test, you'll have 2 minutes to check your answers. Part A. In this part of the test, you'll hear 2 different extracts. In each extract, a health professional is talking to a patient. For questions 1 to 24, complete the notes with information you hear. Now look at the notes for extract 1.
Extract 1. Questions 1 to 12. You will hear a doctor talking to Josh regarding ways to quit smoking. For questions 1-12, complete the notes with a word or short phrase. You now have 30 seconds to look at the notes.
Just to explain, I think there's 2 parts to the quitting now. One is you can use things like replacement therapies, like Nicorette gums and patches and those sort of things. They don't really make you quit. They just offer the nicotine in a different form. So instead of inhaling it, you're taking it through the skin or across the mucous membrane of the mouth.
Yep.
I don't usually see those as a solution in themselves. There are other things you can do of a behavioural technique. The technique that I've used most in the past is hypnotherapy, which is focusing clearly on the reasons why you want to quit.
Right.
And you're focusing on the reasons why you want to keep smoking, and you're substituting and you're emphasising the ones why you want to quit.
Okay.
So you're increasing their status and priority in your mind.
Yeah. Well, that's one thing actually. The hypnotism is one sort of avenue that I've been interested in finding out about, because I don't really understand how hypnotism works.
Right.
And
hypnotherapy is really just using the imagination creatively. You don't achieve things that you definitely couldn't achieve other ways, but sometimes it helps bring it about slightly quicker, more rapidly.
Yep.
I'll come back to the hypnotherapy in a minute. One of the little exercises that I've given many people is to become more aware of the habit of smoking.
Yep.
For example, if you smoked 20 cigarettes the day before yesterday, how many of those do you remember smoking?
What's today? I can't really recall enjoying any of them.
No.
I can't remember.
So what I'd encourage you to do is to say, okay, I'm not going to smoke any more, and I'm not going to smoke any less, but I'm going to become more aware and more observant of how I'm feeling, what I'm thinking, and more importantly, how I'm feeling as I have each cigarette.
Yeah.
So those 20 cigarettes, at least you get your money's worth, rather than just money going up in smoke. The other area that's important is a psychological term called pattern intervention.
Right.
And pattern intervention is where you go about life slightly differently to bring about a different result. What are your patterns?
Oh, that's definitely one. I get up and I make a cup of coffee and then I have a cigarette and a coffee.
Yes.
I always have a cigarette after I eat.
After you've had food?
Yes. Like a meal just doesn't feel complete if I don't do that.
No.
I have a cigarette with coffee, like when I have a coffee later on in the day, which I usually go to a cafe on the campus and sit down and have a cigarette there.
Is there any way you could change those patterns? So with breakfast, is there anything else you could do? Could you have a glass of water and walk outside and
Oh, I suppose
what could
so,
you
but I
do
usually
differently?
feel so sluggish in the morning until I had that cigarette.
What could you do?
Yeah.
What could you do? If you really wanted to do it, what might you do?
Well, I suppose, that idea of getting up and going outside is, considering that I want to improve my overall fitness as well.
Walk around the block.
Yeah.
Say.
Yeah.
These are just suggestions. I'm not saying you should do any of these.
No, but that's actually quite a good idea to me, to my mind. Yeah.
It needs to be something you feel you want to do. Something you feel you could do and you could enjoy doing.
Yep.
And it's got to, in time, be capable of being more enjoyable than having a cup of coffee with a cigarette.
Right. That's going to be an idea to really,
So you might try different things. You might try a glass of water. You might try going outside and having 10 deep breaths. You might try walking around the block.
Yep.
Before I see you next time, I'd like you to do some homework.
Okay.
Would you be happy to do that?
Yeah, sure.
I'd like you to consciously become more aware of each cigarette that you smoke.
Yep.
That's the first one. The second thing is I'd like you to write down on paper when I smoke and what the patterns are when I smoke.
Okay.
And possible ways in which I could modify those patterns. I'm not saying to do it straight away, but say, look, what are all the possibilities?
Sure.
Write them down. We'll look at the choices and we can discuss them next time.
Okay.
The third thing is I'll give you a little handout on hypnotherapy.
Right.
You can have a think about that and we can talk about that. Perhaps we could discuss it in a week or two when you're 1 week closer to quitting.
Fantastic.
How does that sound?
That sounds good.
Okay.
All right, thanks.
Very nice to meet you.
You too. Thanks very much.
Good.
Cheers.
Catch up next time.
Great, thanks.
Bye.
Extract 2. Questions 13 to 24. You will hear a midwife talking to a pregnant patient called Jenny on her first prenatal visit. For questions 13 to 24, complete the notes with a word or short phrase. You now have 30 seconds to look at the notes.
Hi, Jenny.
Hi, Sue, how are you?
Good. Congratulations.
Thank you.
On your pregnancy.
Thank you.
Now, I'm one of the midwives in the antenatal clinic, so you'll probably be seeing quite a bit of me during your pregnancy. You'll see a few midwives through the clinics, but we all work down here, so you'll see a few of us.
Do I see
along
you
the way
each time, or does it?
Not each time, but just probably a few here and there. Just depends what days we're on and when you come in for your visits. So we just, with the first visit, this is the booking visit. So we just go through a variety of things, just looking at your medical history and talk about some things in pregnancy, and then if you've got any questions along the way. So
I've got a list ready.
A long list, great. Okay. Now, this is your first pregnancy?
Yeah.
Okay. And you've had no other pregnancies before then?
No.
Okay. Now, just with your due date and things, I just want to find out, when was your last, first day of your last period?
Was about January the 26th.
Okay. And do you have a regular cycle or irregular cycle?
Yeah, no, it's regular.
It's regular. How many days?
28 days.
Okay, that's fine. So we'll work that out for you and give you the exact date. You had an ultrasound at
I had
8 weeks?
Yeah.
Okay, so we'll get the results of that, and that'll give us also an accurate date for you
for the
due date as well.
Although it's how often is it on the due date?
Never.
Okay.
No, not never, but your due date's actually a month, so it's anywhere from 37 to 42 weeks, so it's the due date is really definitely
so kind of
estimate.
2 weeks either side.
2 weeks either side of your due
date.
And any problems falling pregnant? You had no
problems? We I'd been on the pill for like 15 years or something, and we thought it would take a long time perhaps when I went off it, but
Sure.
yeah, first month.
Yeah, okay, that's fine. We have to ask this question. You're not related to your husband?
No.
No? Okay. No family history of any hypertension or diabetes or cardiac problems?
No.
No? Okay. And no other surgery? No, you have ever had a general anaesthetic or anything?
I had my tonsils out.
Tonsils out. And
When I was about 20, and I was
okay.
fine.
And no problems with the general anaesthetic?
No.
Okay, that's fine.
Yeah, the only thing I wanted to mention is that I have osteoporosis.
Okay.
And so I wanted to talk about that a little bit because I have a specialist I see for it, and we've discussed pregnancy, and he says that he doesn't think being pregnant itself is an issue for the body because you take calcium supplements, but it doesn't take calcium directly from your bones.
Okay.
But he suggested thinking about whether to breastfeed or not because breastfeeding takes calcium directly from the bones,
Sure.
which may cause fractures. And he's dealt with 2 women who've had osteoporosis and been pregnant before. One was fine, and the other one had a lot of fractures even during the pregnancy. So I feel really bad about not deciding whether to breastfeed or not. 'Cause
Sure.
There's a lot of pressure.
Yeah.
People, all the magazines and everything have.
Yeah,
it's
yeah.
best to breastfeed. Your baby will have higher IQ if you breastfeed. All that kind of stuff.
Sure.
So,
I think it's important though to also look at your health first. So as important as breastfeeding is, I think it's also important that you need to look after your health. So the formulas and things these days that babies have are very close to mother's milk anyway. So and I think it's probably best to go with what your physician says. So.
That is the end of Part A. Now look at Part B. Part B. In this part of the test, you'll hear 6 different extracts. In each extract, you'll hear people talking in a different healthcare setting. For questions 25 to 30, choose the answer A, B, or C, which fits best according to what you hear. You'll have time to read each question before you listen. Complete your answers as you listen.
I would just like to talk to you about Always events. We've been working with patients and staff to translate our values into some simple practical actions that will make a real difference to everyone's experience of care. Things that we should always do, such as ask a patient for their opinion when it comes to their care and needs, listen to them and treat them as we would like to be treated. We'll be focusing on a different aspect every month, beginning with the importance of asking patients and families for their opinions, asking them what they wish to be called, and always introducing ourselves. You might have heard of the Hello, My Name Is initiative started by Dr. Kate Granger, which encourages all staff to introduce themselves to patients and families. We agree that this is a great way to begin a new interaction. When you're busy, it's easy to forget that little things make a huge difference to our patients and visitors' perceptions of the quality of care we provide. So we'll be displaying these actions around our hospitals to remind us all to pause and consider if we're treating everyone as you would wish your loved ones to be treated.
Okay, Kate, can you tell me a little bit about the new stroke admission that came in?
Yeah, Mrs. Novak was admitted late last night to ED where she was presenting with left-sided weakness. Her husband confirmed that she collapsed whilst at home and was brought in by ambulance to ED where they confirmed with CT that she did not have a hemorrhagic stroke. Therefore, she underwent TPA therapy and was transferred to our ward this morning for assessment and management.
Okay, good. Can you tell me what you understand by TPA?
Okay, well, it's used as a clot-busting agent in the management of ischemic stroke.
Yep.
And if administered within 3 hours of symptom onset, has been shown to reduce morbidity and mortality.
Good, good. Now, can you tell me what your plan is going to be for today?
Okay, I'd like to do a functional assessment, just so the nursing staff are aware of her capabilities overnight, and then tomorrow I'll aim to do a full assessment.
So Tiffany came in, she had a melanoma in 2000 and she's had an excision of that lesion in 2000 and breakdown. She's got past history of arthritis and she's a current smoker. Tiffany's from Merkel's. Yeah. She's on BD OBS and a daily BSL. We had a fall yesterday.
When was the pain relief next due? Just so Tiffany knows.
So she had it this morning. Basically, it's just a PRN. Means she can have it whenever she requires. She just needs to use that call bell, and we'll get on top of it.
There have been lots of other developments to improve how our clinical staff use technology as we work towards a paperless state by 2018. Some of these developments include enabling more staff to check the child protection database, recording on QuadraMed patients who are being looked after on a ward that doesn't specialise in their condition, supporting Year 5 medical students to use QuadraMed to better support their colleagues on the wards, providing easier access to patient letters, better notification of patient involvement in clinical trials, and a new clinical systems forum for foundation doctors. And that's it for this month's Team Brief podcast.
This is a demonstration of how to perform trach care on a patient. I will begin by gathering my supplies, a trach care kit, non-sterile drape, a bottle of peroxide, and a bottle of normal saline. My yellow gown, my personal protective equipment to protect myself from my patient's secretions. I have a mask with a face shield, but for demonstration purposes so that you can hear me, I will put it to the side. You do not need to have an order to perform trach care. It is nursing care. You will go by your hospital policy. It's normally once a shift and PRN. I will wash my hands, introduce myself to the patient, and with the patient's chart, I am going to check their identification bracelet, noting their name, their birth date, and medical record number.
At Maimonides, we have a wonderful preceptor program where the nurses work alongside another nurse from the time they're off classroom orientation to help learn how to admit these patients from surgery and how to care for them. So this time, instead of just connecting, I'm connecting and saying things aloud and directing her in terms of how to do something. You know, the patient had a good heart rate, the patient had a good blood pressure, so we could do things a little slower than we would if I was just doing that alone. So it's definitely a big part of what we do as nurses in CTICU and throughout the hospital, simply because in order to continue having a good pool of nurses to take care of the patients, we have to train them. And the best way to train them is to have them work alongside another nurse whose skills are up to par to teach other nurses.
That is the end of Part B. Now look at Part C. Part C. In this part of the test, you'll hear 2 different extracts. In each extract, you'll hear health professionals talking about aspects of their work. For questions 31 to 42, choose the answer A, B, or C, which fits best according to what you hear. Complete your answers as you listen. Now look at Extract 1. Extract 1, questions 31 to 36. You now have 90 seconds to read questions 31 to 36.
Mercury in fish. Mercury is a naturally occurring element that is found in air, water and food. Most people are exposed to mercury via food. Fish take up mercury from streams and oceans as they feed. This mercury is in the more toxic methylmercury form. It binds to their tissue proteins such as muscle. Food processing, preparation and cooking techniques don't significantly reduce the amount of mercury in fish. Methylmercury is the most hazardous. Mercury is common in the environment and has 3 forms: organic, inorganic and metallic. The organic form of mercury, particularly methylmercury, is the most dangerous. Fish absorb methylmercury. Methylmercury in fish mainly comes from mercury in ocean sediment that is transformed into methylmercury by microorganisms. This organic form of mercury is absorbed by the tissues of fish through their gills as they swim and through their digestive tracts as they feed. Some fish contain more mercury than others. Mercury levels differ from one species of fish to the next. This is due to factors such as type of fish, size, location, habitat, diet, and age. Fish that are predatory, eat other fish, are large and at the top of the food chain and so tend to contain more mercury. Fish that contain higher levels of mercury include shark, ray, swordfish, barramundi, gemfish, orange ruffy, ling, southern bluefin tuna. Fish with lower mercury levels. Examples of fish that contain lower levels of mercury include shellfish, including prawns, lobsters and oysters, salmon, canned tuna. Fish as part of the diet. Fish is an important part of a healthy diet. Some of the health benefits of fish include that it is high in protein, low in saturated fat, high in unsaturated fat, high in omega-3 oils. For healthy adults and children, mercury from most fish sold in Australia is not a health risk when fish is consumed as part of a normal diet. However, fish with high levels of mercury like shark or flake, should probably not be eaten more than once a week. Mercury and the unborn baby. Unborn babies are at increased risk from mercury. The mercury in fish can lead to raised mercury levels in the mother. This mercury can be passed on through the placenta to her developing baby. The fetus appears to be most sensitive to the effects of mercury during the 3rd and 4th months of a pregnancy. The effects on the brain and nervous system may not be noticed until developmental milestones, such as walking and talking, are delayed. Memory, language and attention span may also be affected. International researchers recommend reducing safe levels of mercury. Studies of the brain development of children whose mothers ate significant amounts of fish with high mercury levels during pregnancy have been carried out in New Zealand, the Faroes and the Seychelles. The Joint Food and Agriculture Organization, FAO, and World Health Organization, WHO, Expert Committee on Food Additives, JECFA, reviewed these studies in June 2003. These researchers recommended reducing the amount of fish known to contain mercury in the diet, particularly for pregnant women. Australian research shows that mercury levels in some fish, particularly shark, could be even higher than in the areas studied for this research. In fact, it seems that mercury levels in some shark species caught in Victorian waters are particularly high. Australian guidelines for safe levels are under review. Since the joint FAO and WHO Expert Committee, JECFA, revised its guidelines on methyl mercury, Food Standards Australia New Zealand, FSANZ, has also begun to review its advice on the consumption of fish during pregnancy. When the review is completed by FSANZ, they may give further recommendations.
Now look at Extract 2. Extract 2. Questions 37 to 42. You now have 90 seconds to read questions 37 to 42.
Bairnsdale ulcer. Bairnsdale ulcer is a skin disease caused by the bacterium Mycobacterium ulcerans. The toxins made by the bacteria destroy skin cells, small blood vessels, capillaries, and subcutaneous fat, which leads to ulceration and skin loss. These bacteria are found naturally in the environment, but the mode of infection to humans is unknown. Native and domestic animals can also be at risk. The Bairnsdale ulcer is not thought to be contagious. It gets its name from the local area in which an outbreak among farmers was documented in 1948. Since this type of ulcer is found in other parts of Australia and around the world, it has many names, including Daintree ulcer and Buruli ulcer. Its medical name is Mycobacterium ulcerans, MU, infection. MU is a rare infection, although the number of cases in Victoria varies widely from year to year. Symptoms. The progression of symptoms can include A spot that looks like a mosquito bite forms on the skin. The spot grows bigger over days or weeks. The spot may form a crusty, non-healing scab. The scab then disintegrates into an ulcer. The ulcer continues to enlarge. Unlike other ulcers, this ulcer is usually painless, and there is generally no fever or other signs of infection. The limbs are more commonly affected. The infection may sometimes present as localized pain and swelling with fever, but no ulceration. The effect of toxins. Mycobacterium ulcerans is related to the same family of bacteria responsible for leprosy and tuberculosis, but, unlike them, is not contagious. The toxins made by the bacteria destroy the skin and the fat layer beneath it, and block the small blood vessels that service the infected areas. These toxins are also thought to have a dampening effect on the person's immune system, which means the body has less chance of fighting the infection. In severe cases, the infection can destroy bone and cause lifelong deformity and disability. In developing countries, common complications for people who are unable to get adequate medical care can include amputation and the loss of affected organs such as the eyes. Locations of recent outbreaks. Mycobacterium ulcerans infection has been reported in at least 32 countries around the world. Affected areas include rural West Africa, Central Africa, New Guinea, Latin America, and tropical regions of Asia. In Australia, MU most commonly occurs in localized coastal areas of Victoria, where cases have been reported from East Gippsland, the Mornington Peninsula area, Western Port and Phillip Island, and the Bellarine Peninsula. Most recently, there has been a large outbreak associated with the small township of Point Lonsdale. It also occurs less commonly in the Daintree region of far north Queensland. Treatment options. Since the ulcer gets bigger with time, early diagnosis and prompt treatment can keep the amount of skin loss to a minimum. The first line of treatment is generally surgery to cut away the dead skin. A surrounding portion of healthy tissue is also cut out to make sure the infection is completely removed. Depending on the extent of surgery, skin grafts may be needed to close the wound. Prevention strategies. The cause of infection in humans is not known. As the bacterium is environmental, requires particular conditions outside the body to exist, it makes sense to protect yourself from potential sources of infection such as soil and insect bites. A recent study on mosquitoes trapped in the Point Lonsdale area has shown them to be contaminated with the same bacteria that causes Bairnsdale ulcer. It is important to remember that the risk of infection is very low, even in those areas where the ulcer is endemic, constantly present in the community. Suggestions to reduce the risk of infection while working outdoors or gardening include: protect cuts or abrasions with sticking plasters. Promptly wash and cover any scratches or cuts you receive while working outdoors. Wear gardening gloves, long-sleeved shirts, and trousers. Avoid insect bites by using suitable insect repellents. See your doctor if you have a slow-healing skin lesion.
That is the end of Part C. You now have 2 minutes to check your answers.